Hi, good morning. This is the 11:30 session. The title of the session is Reproductive Genetic Testing Options and Fertility When You're 35 Plus. And I'd like to introduce Michelle Kiel, who is the moderator of this session, and Melissa Meisenbacher. And Melissa is the genetic counselor, director of genetic counseling from Natera, and Michelle is the director program development PGD at Natera. So we appreciate both of you being here, and let's get right into the session. Thank you.
Thank you. First of all, I would like to welcome everybody back from the session break. And we are pleased to be here and thank Fertility Planit for allowing us to speak here today. I'd like to introduce the speaker, Melissa Meisenbacher. She's a certified genetic counselor. She's been genetic counseling for 12 years. She's graduated with her master's degree from Notre Dame and also Arcadia University. Melissa has also been genetic counseling for Natera for the last several years. Her specialties are in 22q11.2 deletion syndrome, and that is to do with the inherited cardiomyopathies. And she has a very special interest in infertility. At this point, I'd like to have Melissa start her presentation.
Thank you, Michelle. Good morning. I hope you're all doing well. Today, I'd like to talk a little bit about reproductive genetic testing options and the fertility journey that women 35 years and older go on. 35 plus, I feel, is the nice way, maybe even the more PC way, to say advanced maternal age. I know during my last pregnancy, my doctor said on my very first visit, "Oh, you're AMA." And I thought, this is awful. I don't mind being described as type A, but AMA just seemed like he was telling me I was really old, and it really kind of stung. Before I continue, I'd like to tell you a little bit about myself. So as Michelle mentioned, I am a board-certified genetic counselor. I work for Natera, a company focused on reproductive genetic testing. Previous to working for Natera, I was at both the Children's Hospital of Philadelphia and the University of Florida in pediatric genetics. I joined Natera when I was pregnant with my middle daughter in 2009 because of my interest both personally and professionally in helping couples with infertility. I now have 3 children. I live in Virginia Beach, and I try my best to balance my work life and my family life, and sometimes I try and throw in my own life as I go along. So when I'm faced with really challenging situations, I like to think of them as a boxing match. In college, it was always me versus the final exam. When I go to the gym, it's always me versus the treadmill. And unfortunately, in life, it was me, or it can be you, versus infertility. And so today, I'd like to talk about how genetic testing can help you win each of these bouts as you stand across the ring from your biological clock, your possible pregnancy loss, and infertility. So the first opponent is your biological clock. This TikToker can be really tricky. You can go and read in the popular press that sometimes it really doesn't get started until you're 35. Then you'll read in the next article people saying it actually doesn't start going until you're 40. How many of you believe that your fertility doesn't start to decline until you're 35? How about not really until you're 40? I mean, we know lots of people that got pregnant between 35 and 40, right? I mean, so based on miscarriage and pregnancy rate data, around age 35 is really when the chance of miscarriage starts to go up and fertility starts to go down. So it's kind of a double whammy right around age 35. Also around age 35, the chance of having a baby with a chromosome abnormality starts to rise. So our chromosomes are what house our DNA, and DNA is kind of like the instruction manual for our body. So you have to have the right amount. If you have too much or too little, it can cause problems. So at 35 years old, your chance of having a baby with a chromosome abnormality is about 1 in 200. And by the time you reach 45, it's about 1 in 20. And so that's a 10-fold increase that happens over those 10 years. One of the most common chromosome abnormalities is Down syndrome, but there are many, many others that can result in children with intellectual disabilities and birth defects. So, what's a 35-plus gal to do? There are 3 good genetic testing options in your corner. First are the traditional screening methods. This includes ultrasounds, maternal serum screening. Second are the new non-invasive prenatal testing or screening, also called NIPT or NIPS. Some of you may have been at the Ariosa-sponsored talk this morning where they went into a lot of detail about NIPT. And the third is invasive prenatal diagnostic testing, so a CVS or an amniocentesis. So for me, punch 1 is the traditional prenatal screening. So this type of testing has greatly advanced since the 1960s. Back then, a doctor just looked at your age to say whether or not you were high risk. This was not super useful because the detection rate was only about 25%. In the 1980s, they started discovering that analytes in the maternal blood could indicate risks for chromosome abnormalities in the baby. So first, they looked at alpha-fetoprotein levels, or AFP levels, and then 2 other analytes were added to this screen. And this created the triple screen in the late 80s. And then the detection rates jumped up to 75%, which is okay, it's pretty good. In the late 90s, first trimester screening, or the quad screen, or the integrated screen was introduced. With each of these steps, the detection rate got a little bit better. But now, in 2013, there's non-invasive prenatal screening, or NIPT. This has extremely high detection rates, and they vary somewhat by test methodology. So this leads right into punch 2, non-invasive prenatal testing, or NIPT. How many of you have heard of NIPT? Anybody? Okay. Anybody had NIPT? Good. Yeah. So with my last pregnancy, I had NIPT. I participated in a research trial for NIPT because it wasn't commercial yet, but I thought I will participate in this research trial. So with NIPT, what it does is it allows for identification of circulating DNA from the baby in the mother's bloodstream. And so it allows you to have a non-invasive test with no risk of miscarriage to look at fetal DNA or baby DNA from a maternal blood draw. There are 4 companies, including Natera, which offer this type of testing. Currently, all the companies screen for trisomy 21, which is Down syndrome, trisomy 13, and trisomy 18. Some companies are also able to screen for the X and the Y chromosome. And Natera also offers detection of triploidy, which is an extra copy of every single chromosome. With NIPT, you get to have higher detection rates. So the detection rates are usually close to 99%, and very, very few missed cases. So this is really the newest non-invasive testing on the market. If you've gone through these testings and you still haven't knocked out your biological clock, you can try punch 3, which is invasive prenatal testing, either a CVS or an amniocentesis. Both of these tests do carry a risk of miscarriage just due to the procedure, and so a lot of patients shy away from these tests, and oftentimes they're not recommended for patients who are at low risk or who can have other non-invasive testing that don't carry that risk of miscarriage. So here we have one example of one of our champions of round number 1 versus her biological clock. So this patient was at an increased risk to have a baby with Down syndrome because of her age. She was 36. She had Natera's Panorama testing done at 10 weeks, and before she was out of her first trimester, she knew that her risk to have a baby with Down syndrome, trisomy 13, trisomy 18, and monosomy X or Turner syndrome were all less than 1 in 10,000. And so she didn't go ahead to have any invasive procedures. There are other champions of round 1 that also exist. There will be those patients that get a positive result, either from a non-invasive test or from an invasive test. And these patients will be better able to make decisions for their pregnancy. They will be able to look at what do they want to do with that pregnancy, how do they want to manage their pregnancy, do they want to continue their pregnancy, where do they want to deliver, and they're better able to prepare to have a child with a chromosome abnormality rather than having this overwhelming shock in the delivery room of your baby has a problem. So now, on to your second opponent, pregnancy loss. Losing a pregnancy or having a miscarriage is really common. Up to 1 in 4 women, or 25% of pregnancies, are lost in a miscarriage. And so you probably all know someone that's had a miscarriage. I know lots and lots of people that have had miscarriages. Especially now that people are taking these very early home pregnancy kits, you find out you're pregnant so much earlier. And there's an increase in maternal age across the population, which is leading to more people reporting miscarriages. Again, here's the same chart. So you can see that the rate of miscarriage increases drastically with age. It's only about 10% when you're 20, and it goes up to 50 to 90% when you're in your mid to late 40s. Very importantly, more than half of spontaneous miscarriages have chromosome abnormalities. Most commonly, these are missing or extra copies of some of the chromosomes. And this holds true over a wide span of ages. This is not just true for women over 35. It happens in all age groups. Because of the high incidence of chromosome abnormalities and pregnancy loss, genetic testing can be really helpful to find out why you had a miscarriage. So without genetic testing, 80% of pregnancy losses are unexplained. Your doctor doesn't know why it happened. But with genetic testing, that drops down to 18%. So genetic testing is really able to give you a lot of answers. So this leads to punch 1, which is products of conception testing, POC testing, or miscarriage testing. This type of testing can identify a cause of a miscarriage in somewhere between 50 to 75% of miscarriages. For many people, understanding why you had a miscarriage or that there is an actual cause for that miscarriage can be really helpful and help you move on past that miscarriage. It can also help your doctor in limiting the number of other tests that they want to do on you to see why did you have a miscarriage. It sometimes can also identify couples that might be at a higher risk of having another miscarriage. So importantly, not all punches are created equal. In order to have the hardest hit, POC testing using a genetic array is much more powerful than the old traditional karyotyping. So Natera offers miscarriage testing using a SNP array. It gets back fast results. The results come back in 5 days. It detects many different types of genetic problems. And it makes sure that the results you're getting are actually results from the baby, not from mom. Lastly, and really importantly for some couples, is that you're able to go back and test losses that you had years ago if your doctor stored them in a pathology lab in paraffin. So you can almost take a time machine back to say, what was the cause of my previous loss, and can we figure that out? Most patients, for their first loss, will not have genetic testing offered to them. And then once you get to your second or your third loss, a lot of times it's too late. And you say, well, what if I had had testing before? And so this can allow you to get some of those answers. And so here are some of my champions for this round 2 pregnancy loss. So first is a 42-year-old patient. She had recurrent pregnancy loss, and her last loss was at 8 weeks gestation. So her doctor ordered testing, and it showed actually that all of the chromosomes in the baby came from the dad, and the mom hadn't contributed any. And usually half should come from mom and half should come from dad. And this is indicative of a molar pregnancy, which actually carries some health risks for the mother. So it was really helpful for this patient to find out that she should be monitored for her own health risks, and it helped that doctor guide this patient's care. And here is my favorite champion of this round, because it was so lovely to get to speak with her and her husband. So she was a 37-year-old pregnant patient who had had 4 previous losses. She had a natural pregnancy, and she had miscarried at 10 weeks. And she was absolutely positively convinced that every single one of her eggs was bad, and that her next step had to be IVF with an egg donor, because she had had these losses and now they were doing testing. And it actually turned out that the chromosome abnormality came from the sperm. And so her husband was so thrilled to say, it was me, it wasn't you, it was me. And he took this blame from her. And so she was able to go on and continue to try and have her own biological child, which is what she really wanted. So last but not least is U versus infertility. Infertility is really common. It is much more common than most people realize. About 10% of American couples have infertility. I give some lectures to med school classes, and I make 1 out of every 10 students raise their hand. And I say, all of you will have problems with infertility. And it's shocking that it is such a high percentage. Kim Kardashian, Hugh Jackman, whom my son calls Wolverine, he refuses to think that he's actually a real person. Juliana Rancic, Mariah Carey, Nicole Kidman, Courtney Cox. I mean, the list goes on and on for famous people that we hear with infertility, but it happens to regular people too. My personal favorite is the couple from Up, who have the most beautiful love story and also suffer from fertility problems. So when faced with infertility, there are conventional therapies that help in most cases. Lifestyle changes, surgery, medications, all of these things can help. About 10 to 15% of couples do need to go down the road of assisted reproductive therapy, or ART, which most commonly is thought of as IVF. And if you do need to go down the road of IVF, reproductive genetic testing can help you out. So the first punch for infertility is embryo genetic screening, which is referred to as pre-implantation genetic screening, or PGS, or sometimes they say PGD. So this screening is able to help your doctor select the embryo or embryos that are most likely to result in a healthy pregnancy. PGS screens for missing or extra chromosomes. And this is important because most miscarriages are caused by missing or extra chromosomes. At Natera, PGS testing has resulted in implantation rates at over 50% for patients across all age groups. So it acts as an equalizer for women that are older compared to women that are younger. So this is in stark contrast, as you can see here, to the data collected nationally by SART, where there's this rapid decline in pregnancy rates over increasing maternal age. But with PGS testing, it stays fairly flat. So this is our champion number 1 for infertility. So many patients have been through lots of fertility setbacks before they get to IVF and before they get to PGD, like Jennifer. So she wrote, after she had multiple unsuccessful attempts at conception, she tried insemination, then she got pregnant, then she had a miscarriage. The PGS testing that she did at Natera provided her with peace of mind as they tried their first IVF cycle. And it worked, and now they have a healthy baby girl. Here is another champion for round 3, I'm sorry. So this couple went through IVF with PGD, or with PGS, to select female embryos. They had a genetic condition in their family that affected only males. And so they had unsuccessful PGS testing with other methods, and they decided to go ahead and try using the PGS testing at Natera, and they now have healthy twin baby girls. There are other champions who also exist, other champions that may not actually end up with a baby. These will be people who get added information from PGS testing, information that helps them make informed decisions about when to continue trying to have a pregnancy, when to think about using donor eggs or donor sperm, and when it might be the right time to stop trying to get pregnant and think about other options for creating their family. These patients are also champions, and we need to recognize them. So here's the score. Reproductive genetic testing, 3. Fertility problems, 0. And so we at Natera hope that some of this is able to help you as you plan your fertility journey, as you plan your dream family. And we hope that reproductive genetic testing will give you that extra oomph, that extra kapow, as my son would say, to knock out those problems. So thank you very much. And if you have questions, we would like to try and answer them.
I have a question. I should identify myself as that. I am with the press and covering this. I hear you talk about infertility. Sorry, and I was born at the end of 1959, so I grew up thinking, really, if I didn't get it by 30, fine, move on. And I'm concerned that a lot of people have misconceptions of what true infertility is. Age-related infertility, which really phases in from the age of 28. And when you say, oh, so-and-so had infertility and they're 38 or 40 or 42, I mean, even 38, this is age-related, isn't it? So when you say infertility, to lump a 25-year-old in with a 38-year-old, like I'm just kind of wondering if you're not kind of obfuscating what the real bio clock of women is.
So I think that there are lots of causes for infertility. We focused on the age-related causes here because we really were thinking about women 35 years and older during this session. But you're right, there are other causes of infertility, and those other causes are more common in younger women.
Is there any other questions from the audience? Well, I have a question for you, Melissa.
Sure.
You mentioned that the panorama test can detect certain chromosome abnormalities and copy number. Could it also tell you whether or not you're a carrier for a genetic disease?
No, so what you're asking about is the non-invasive prenatal testing that Natera offers is called Panorama. So with Panorama testing, we are not able to screen parents for genetic diseases. That would be a separate genetic test that your doctor would order called carrier testing. That testing is offered through Natera. And that would screen for genetic diseases like cystic fibrosis or sickle cell anemia, or there's a Jewish disease panel, and that would screen for those genetic diseases. Tay-Sachs would be a good example of a disease on the Jewish panel.
I don't want to be the contrarian, but tests have shown, I mean, the research is coming out now that men over 45 who father children have a much higher rate of producing bipolar and especially schizophrenic offspring. And there's also a lot of research being done by Dr. Barad is one person. He had been my fertility doctor years ago about what the fetal abnormalities that result from this, but also certain things are simply age-related from the father's side, and it has to do with the age of the father. And I'm just wondering, how, like what, I know that you're there to screen, but I don't know that a lot of people in the past knew when they were fathering children at a young age that they were going to wind up with, kids with Asperger's and autism on their hands. So I know I'm sounding reductive and negative and oversimplified, but I just hear all these like bubbles of happiness, and I know so many people who've gone through this, and the outcome has not been, the wonderful, the champions, the little bow in a package. There's a lot that comes with the responsibility of being an older parent and possibly having offspring that are going to suffer from your choice.
I hear you. So first, you're right. There is research out there that shows that there are some negative effects from an older father. That is new research that's coming out. It's mostly looking at fathers 45 years and older. Those types of problems are not screened for as part of the non-invasive testing. It really looks only at chromosome abnormalities, not at things like bipolar, Asperger's, autism. I think there are lots of challenges that go along with being a parent across all age groups. I think that you could pick out challenges that go along with being a teenage parent, challenges that go along with being a parent in your 20s, challenges that go along with being a parent in your 30s, and definitely being a parent in your 40s or 50s. You change, your economic situation changes, your family dynamics all change, for better or for worse, in different points of your life.
I just want to make a point that you can only check for things with your testing if there's a known connection between a disorder and what we're finding in chromosomal testing. So if there's no known connection right now, say between Asperger's and chromosome abnormalities, you couldn't find it.
You're correct. So what he stated was that we need to have a known cause for a problem, a known chromosome cause for a problem in order to be able to test for it. And you're absolutely correct. And for the case of autism, most cases of autism are unknown. They are probably a combination of genes plus environment plus something else we don't understand. There are a few cases of autism that are caused by known chromosome problems, like Fragile X. But for the vast majority, you're correct. We don't understand the causation.
I wanted to make a comment also about the increased risk of having a baby with Down syndrome if you are pregnant before the age of 18. That's also a very high risk, as well as in your 40s. So it is age-related, even when you're a teenager.
There are some problems that are more common for younger women. Actually, some birth defects, even that aren't chromosomal, that are seen more common in young mothers. And we do know that the vast majority of babies with Down syndrome are born to mothers that are under age 35, because those women are having more children.
Any other questions?
Question? Sure. Here, take the mic.
I don't know if it's a question for you or not, for Natera, but for example, I cryopreserved my eggs, but there's no way of testing them to see if they're okay or not unless they're an embryo. Why is that? So, you know, I'm going to have to wait until we turn those into an embryo.
There is some testing, and it's called polar body testing for the chromosome number. That is not showing, that would actually be just testing your egg. And in order to do that, for the actual definitive answer, is what happens is once the egg becomes mature, it has a polar body. That polar body could be biopsied and then tested. And then that shows what's in the egg. But that also has been proven in literature that that's really not always a true benefit and true factor of what the egg is actually representing. Because sometimes during what genetic division and duplication happens is that you end up having abnormal meiotic disjunction. And what happens is then instead of the chromosome copy number splitting completely in half in a uniform way, meaning half of the chromosomes go into a polar body and the other half stay in the egg, sometimes that doesn't happen. So that's why most testing now that you're seeing is from an embryo, and you're also able to tell the paternal end also in your chromosome testing.
I was just going to say
So, but if you do, once you do thaw your egg and you have an embryo, you could go ahead and have PGS done on the embryos, and that would be able to tell you whether or not you had the correct chromosome copy number, or what we in science call as a euploid embryo versus an aneuploid embryo.
Thank you.
You're welcome.
Follow-up question, is there a potential for damage to the embryo without testing? To the egg without testing?
To the egg for egg freezing or for
No, the testing is just
the PGS? There's two types of embryo biopsy at two different times. In the beginning, most centers would do day 3 biopsy, which is usually anywhere for an embryo that is 5 cells or greater. And now technology has moved along where we can biopsy at the blastocyst stage, and there's a couple reasons why. Genetic testing, we need lots and lots of DNA. So when you take one cell out of an embryo, you have to amplify that. So the testing with amplification, it's hard to take one cell and duplicate it multiple times. The other factor that we're finding out in literature and in research too, by doing a day 3 embryo biopsy, is that the pregnancy rates have not shown increased pregnancies. And then also there is what we call mosaicism in an embryo. So mosaicism in an embryo, let's say at an 8-cell embryo versus an embryo with a couple hundred cells, we get a better representation on a day 5 blastocyst. So we can actually take a few cells from the section of an embryo that is actually the form that, the part of the embryo that becomes the placenta. So there is some on day 3. Right now, it's really inconclusive as a whole because we have not done this procedure long enough for live birth and for the children to grow up to see if there's any form. That's going to take years of research for that to do. But right now, it looks like the blastocyst biopsy is the way to go. We get better results from PGS testing or PGD testing, and it's less invasive as far as the embryo is concerned from what we're seeing. Better survivability, better development of the blastocyst.
Thank you, everyone. We're at the end of the session now. We appreciate your questions.
If you have additional questions, both Michelle and I are available, and we would be happy to answer those out by the Natera table. Thanks.
Thank you.